This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about physician-led interprofessional teams with Mike Christian. So Dr. Mike Christian is a senior author of the systematic review and meta-analysis on physician-led interprofessional pre-hospital teams. So for over 3 decades, the role of physicians in pre-hospital care has grown significantly. So Mike's research demonstrates the transformative impact of interprofessional teams, bringing together physicians, paramedics, and other specialists to enhance care delivery and improve patient outcomes. So this episode explores the evidence behind these teams. We also shed light on the ability to reduce mortality, improve survival, critically injured and ill patients. So we're going to walk through some of the benefits, challenges, and indeed future potentials of these teams, touching on their training, logistical, and systemic considerations that shape their implementation. So Mike began his career as a paramedic and is now a critical care physician, researcher, and educator in PHEM. He's based in Canada. He specialises in interprofessional team care for critically injured and ill patients. He's held leadership positions across the spectrum, really, but certainly in PHEM and hospital systems in the UK and Canada. Welcome to the podcast, Mike.
Thanks a lot, Owen. It's great to speak again.
It's fantastic to have you on, actually. Mike, I just wonder if we could start with the genesis of this research and indeed what motivated you to explore the impact of physician-led interprofessional pre-hospital teams on critically injured and ill patients.
This actually grows out of a bigger project, and that's probably a separate podcast, but I've been working with a group of mostly rural clinicians in British Columbia that have been looking to try and address some of the long-standing changes and gaps in pre-hospital and retrieval medicine in British Columbia. So we were, as part of looking at developing a new organization to support that work, we were doing a large and fairly extensive literature review. And this topic of the models of care was just one of them. I had a couple of senior medical students, final year medical students, Matt and Arsh, who were working with me. And they were looking at this material, and they actually came to me. We were planning to do just a more of a qualitative review of the literature in this area, and they came to me and said they think there's enough for a meta-analysis. And I, to be honest, was quite skeptical. I was familiar with the literature. There's a lot out there, but didn't think, given the lack of common outcomes and standardization at the moment, that the data would be there. But as it's always best to do, hire people that are brighter than you and listen to them. And they, so I sort of challenged them, said, okay, well, go away, come back, show me what you found in terms of articles and this, are there enough related to with a common outcome that we could actually do a systematic review? And they came back and had this a series of articles that actually all had a standard outcome. There are a much broader set of articles that talk about different areas, but this group had a common outcome around either mortality or survival. So I supported them to go forward and do a meta-analysis on this, and that's how we got to this paper.
Could you speak to the findings actually in the meta-analysis? Could you maybe speak to the findings, particularly in response to survival and mortality?
Sure. So we started with screening the usual sort of standardized format for a meta-analysis of over 2,000 some odd papers, narrowed it down to 23 papers that really fit the inclusion-exclusion criteria. And these came from 10 countries around the world. In total, there were 300,000 plus patients that were included in the cohorts. And then the analysis was done looking at two different areas based upon how the original study was done. And we can talk a little bit more about that later, probably, uh, whether it was looking at mortality or survival, and specifically comparing the models of care. So not just whether the patient was transported by helicopter or ground, because that has a different effect. So we really narrowed it in on studies that looked at comparing interprofessional teams. And it was truly, it's not just about physician led, but it's about interprofessional teams with physicians and other providers. In most cases, it was paramedics, but sometimes it was critical care practitioners that could have come from either a paramedic or nursing background with a uni-professional team of only paramedics, the standard of most ambulance care in the area. And all but one of these teams provided ALS as the standard of care. So we looked at that, and then the findings came out showing that the interprofessional teams were associated with decreased mortality by about 20%, so an odds ratio of 0.8, and 49% increase in survival in the studies that measured survival, so an odds ratio of 1.49, and both of which were highly statistically significant.
So let's dig into the methodology, actually, Mike, if that's okay. So I believe you used the PRISMA guidelines, which is a robust, empirically proven methodology. Could I get you to speak to maybe some of the challenges you faced during the systematic review and meta-analysis process?
Sure. So there's probably two big buckets I'd put those into. The first is around outcomes and a lack of standardized outcomes, and the second is around interpreting the findings. So we'll start with the standardized outcomes, and the most obvious example is mortality versus survival. So there are a number of other papers out there, and maybe we talk a little bit more later on about the outcomes that are used in these types of papers. But there's no standard set of outcomes for this type of work, which many other fields of critical care and other areas of medicine have developed for their studies. So it's really trying to find a group that you can actually compare. So you're trying to compare apples to apples and oranges to oranges. In one of the sort of when we narrowed it all down, we found papers that focused on mortality and measured mortality outcomes, and those measured survival outcomes. A number of them are risk adjusted for mortality with ISS score and whatnot. And we made a decision not to try and combine them because it's not quite as simple as just doing the inverse and saying that, if their mortality is this, then the survival must be that. We thought that was one step too far in terms of stretching the statistical abilities and the underlying research methodology. So we left the paper as analyzing these in two separate groups. So that was the first sort of big challenge, because even amongst those within mortality, some do hospital mortality, they all either did hospital mortality or 30-day, but they are slightly different outcomes. So it's it's hard to try and aggregate papers when people report things differently. And then the second big thing is interpreting the findings and sort of understanding why the results that you observed occurred. So what we know from the study, because this is an observational study, it's not controlled in any way. What we can really tell is just that that we found an association with interprofessional teams with the characteristics that I described having improved survival and mortality rates. We don't really know why that is. Now you can try to do some subgroup analysis and sort of looking at the literature and try to suss that out. But that's the question everybody really wants to know is, well, why is this? So we looked at a few things and we tried to build some of this methodology into our study to help with this. So certainly one of the questions is this really a study of just highly educated, highly skilled, highly experienced versus lower skilled, lower experienced, lower educated professionals? And I don't think that's really the case here. So one of the reasons why we limited it to the more recent studies, because some of the older studies in this field, over 15 years ago or et cetera, really were comparing, different skill sets and different types of education. But in the group that we looked at, almost all the paramedics that were included, or the standard care providers, almost all of them were university educated now, often with many years of experience to go into in the field in the first place, and to reach that sort of that top paramedic class. Most of the services had different tiers of professionals, so starting off with something similar to a technician, and then going up to an advanced care provider. So so I don't think that was as much the case in this context. The other area, and I think this one here is where there is a little more possibility for why to explain some of the results, and is this really a trial of critical care versus advanced care, and that's one of the things that comes up. And again, that's possibly, and certainly as someone who strongly advocates for having more critical care out there in the pre-hospital setting, and moving more of critical care to the patient as opposed to the patient to critical care. There's a part of me in my heart that thinks, well, there's something there about that. But also then the rational side of me and the sort of the science side of me says, well, what's the evidence to support that argument? And one of the challenges with the methodology is that not a lot of the studies reported in detail about what procedures occurred in which groups, and who had certain advanced procedures, who didn't. So it's a little bit hard to suss out. You have to look at mostly what their base training was and what their capabilities were. There was a little bit of difference, but certainly it's because these studies are a few years older. It's not what we're seeing now with the enhanced care teams doing things like endovascular procedures and ECMO and precision guided medicine. It was sort of a much more standard package of critical care. And as as well as I do, most of the studies to date, even ones published just by KSS a couple of weeks ago, still don't show that those regular interventions have a big mortality impact, if any sort of demonstrated mortality impact. So it's a little bit hard again to say that that's the difference here, and that is eventually what got us down to the issue around interprofessional teams. And I do think there's something sort of what I call secret in the sauce of bringing different professions together that we've seen across different areas of medicine to really have that impact. And I just recently received an email a week or so ago about a paper that was published last year. So and I hadn't seen it when we were writing this, by Professor Dr. Craig Webster, who's an anaesthetist in Auckland, New Zealand. And his area of focus is around medical error and patient safety. And he looked around the world at interprofessional teams in all different areas of medicine versus uniprofessional teams, or lack of interprofessional teams, and showed a statistically significant mortality benefit with the interprofessional team's introduction. And interestingly, almost the same size magnitude of what we found. And so I do think there's a big piece of this, and that's why we included in the title interprofessional teams. It's not just about sort of the doctor role in particular, because I think if you just throw a uniprofessional group of doctors out there and compare them to a uniprofessional group of paramedics, you're not going to have good results, or as good results in either group. I do think there's something about we're better together, and there is something about this coming together of professions and delivering care that is part of this impact. Can't prove that. Craig's work does more towards that, but it's one of the suspicions. So those are sort of some of the challenges with doing this piece of work.
Yeah, indeed, and it's difficult because, like you said, there's a variety of endpoints and heterogeneity around the definition, certainly from a global perspective, or indeed a multinational perspective of what that looks like, and with various, as you were saying before, various ceilings of care. It's trying to distill that down. There's a couple of interesting papers, and we'll visit those shortly, actually, in the conversation. And I had a really interesting conversation with one of your colleagues, actually, Johannes Strobel, who we're going to have on the podcast in a couple of weeks' time. He's a critical care physician in Germany who's really pushing and advancing both paramedic-led and interprofessional led teams in Germany. And he was saying, there really is room for both in pre-hospital care, and it's almost a yes and rather than an either or. I guess that, that's a segue into a question of around just these interprofessional dynamics. Me and you, Mike, have both worked in high performing teams which have been both physician led and paramedic led, in various guises actually. Could I get you to speak to just how we move past this sense of tribalism and maybe historic protectionism to maybe get through to models of care which are advocated within this paper but embrace both?
Yeah, and I think that's one of the first things is that there's just some of the challenge around language, and when we talk about things like physician led or paramedic led, and although paramedic led usually means just paramedics, um, that's why we included interprofessional as a main part of this title, and even debated taking out sort of the physician led, but that's just the way a lot of these papers have been described, and it's sort of the marker that you have physicians and that sort of level of clinical decision making as part of the team, as opposed to just because you could have other interprofessional types of uh, of teams. Yeah, so it's one of the things, and Johannes and I have discussed this as well, and I think there's a few different approaches. So one of the things I think that I always start with is just having a patient focus. So really going back to focusing on achieving the best outcomes for patients, and focusing on the patient throughout their whole journey, and how that whole journey looks. Because it's not just the pre-hospital section, it's not just the in-hospital section. You really need to look across that right through to recovery and rehab, and ask those questions about what type of care and delivered when and where, by whom and by what teams can achieve those best outcomes for a patient, and particularly decreasing potentially preventable pre-hospital deaths, care closer to home, and mitigating health inequities. Like those are sort of some of that sort of focus as the primary focus, as opposed to focusing on some of the semantics. The second thing is not just to limit it to the patients, but to look more broadly at the system. And then this is really bringing I have a penchant for the quintuple aim of healthcare, and this is really part about bringing that in. So the staff experience, and that's staff both within the pre-hospital setting and the in-hospital setting, because particularly on the retrieval side, when you're looking at how you serve populations across something like a province in BC or across a broad area, the people that you're supporting or that you're serving are not just the patients and their families, but also those that work in hospitals, but also as an enhanced care team. And as you know, you're serving your colleagues who are the other first responders on scene, and looking at things like PTSD and how this moral injury that's suffered by teams who don't necessarily have the backup or know that they have the confidence of someone coming to back them up, and how that can enable them to not only mitigate potential adverse effects, but also perform at their best, because they have that confidence to boldly go forward and know that there's someone there. And then other things like recruitment and retention. So those are some of the systems focus. Then two other big things. One I think is I've sort of put as respect or compassion or caring. And I think pre-hospital care hasn't received the respect that it deserves. And that's whether you're a paramedic or a physician who's practicing in that field. Certainly I have colleagues who are physicians who look at the physicians who practice in this field and look down their nose a little bit at us, as much as we hear about and have seen and experienced previously in my past how paramedics are treated. And I think the people fail to recognize the potential impact that needs to take place on pre-hospital mortality to really move the needle on things like trauma deaths, or really further advance our outcomes in cardiac arrest. And you hear this on occasion. I'm sure you've heard this before, but this attitude in parts of medicine about, well, just bring the patient to the hospital. We'll sort it all out there, and those types of issues we need to overcome. And then I think the final thing is this sort of recognition and what I put down as sort of professional self-regulation. So there is a role for colleges, for paramedics, and regulatory bodies, but I'm talking about more of the day-to-day cultural and recognition or regulation within the profession. And personally, as a physician, I've recognized and long ago that my patients receive better care when I work in an interprofessional team. and that it's something that I not only accept but embrace, and I'm humble enough to recognize that, but also confident enough to say that, yeah, yes, this is better. It's not just about one provider. It's about us working together in a team, particularly delivering a critical care. And that's sort of I'd say, it's not perfect. There are always the exceptions, but a much more pervasive and the accepted standard of culture that is in medicine now. That you look across most areas of medicine, there's multidisciplinary teams or interprofessional teams and oncology and critical care and emergency medicine, et cetera. And we've worked really hard as a profession in medicine to weed out those people or educate and advance and change the mindset, starting right from medical school forward about a physician's role in a team-based care. And I do wonder if it's time for paramedics. There are, I'd say, vast majority of paramedics that I know and talk to, but also have had supports and feedback on this. Embrace interprofessional care and look forward to that, plus the opportunities they have to work in different settings throughout the healthcare system. But there are a small number, for a variety of reasons, that really resist that. And I think it's really up to the paramedic profession itself to make a decision and say, where do we want to sit on interprofessional care? And if we embrace it, then how do we bring our colleagues along to also embrace it?
It's really interesting you say that, actually, because we already have very much interprofessional team working in pre-hospital care on many levels, even within paramedic operational led models. So examples of that would be doctors in reach back mechanisms, so in governance mechanisms where there's a semblance of reach back for online consultation. Doctors certainly within maybe the EOC, so the Emergency Operations Center, filtering calls initially, either within critical care or urgent care, or indeed some other specialisms. But it's interesting because one of the deeper aspects, and to your point, is there's a semblance of interprofessional working across the chain, across the patient chain, and actually even as an analog, we paramedics have really started to work within the domain of hospital over the last few years, and it's brought fantastic learning, I think, to the paramedic profession to be involved within emergency medicine as an ACP, advanced clinical practitioner, or indeed within prison services or within GP services, or indeed emergency departments in various guises as paramedics. So there is this semblance of mutual benefit, as you were saying, and it doesn't always need to happen on scene. There's already embedded systems whereby doctors play fundamental roles in different parts of the patient journey, which equally can add value. And I guess my question on the back of that, Mike, would be, because I would like to talk about training. There's a question before that, because you sent me a fascinating paper, actually, which I'd love to chat to you about interprofessional learning and training. Could we just maybe speak to some of the geographical variation that the paper had to tackle or deal with?
As you mentioned, or highlighted, some of what you experienced in the UK in terms of interprofessional practice certainly isn't what exists elsewhere right now. I think certainly in North America, ambulance services are much more distant from the health system and from that interprofessional practice. When we get to I'll loop it into training in a minute, but I'll push back a little bit on that point around whether or not having different people involved at different times is truly interprofessional practice or not, and whether you achieve the benefits. I think unfortunately there weren't enough studies from different areas to be able to do any sort of real subgroup analysis in this. However, as I'm, those on audio won't be able to see, but as I'm getting grayer and older and starting to become longer in the tooth, I've spent a lot more time thinking about this, and also really listening to and meeting people from around the world that practice pre-hospital care. And I honestly think there are far more similarities rather than differences between services. Sometimes the color of the uniform might be different. Sometimes the shape of the ambulance or whatnot might be a little bit different. But fundamentally, the challenges, the patients, a lot of what we see is very similar. I've had so many experiences where I've sat down speaking to colleagues, listening to their stories, hearing about their challenges, and I'm sitting there going like, this sounds exactly like what we're experiencing in other services I've worked at or at home here. And so I do think there is a tendency for people, and it's a bit of a human nature tendency, I think, to be able to want to dismiss or write off something by saying, oh, it's not generalizable, we're different, we're special, it's always unique here, and you can't transfer that knowledge. And I really do think it's important to look around the world and ask, what is the best things that are happening elsewhere? How is it similar or different to what we're doing? And how can we learn from that and apply it in our system? And it's also interesting when we look at things like Craig Webster's work. His work was also around the world. I can't remember exactly how many countries they had, but it was well over a dozen countries from all these different studies in different fields, yet found a very similar type of results. So I do think that although there are geographical differences, I do think there is something more to learn from this paper, and we should be really reluctant to just say, oh, it's different here, and write that off.
So let's do a deep dive into training because I think it's fascinating. Having been for 10 years as part of London HEMS, I see it as really ultimately the most amazing mentorship role for me, really sitting next to a huge cross section of doctors, of anaesthetists, of emergency medicine colleagues, of GPs, that have practiced doing the physician response unit as well as the critical care response. And that was for me amazing, actually. That's anecdotal, but it's actually, you sent me this paper, and what it's really fascinating is that in January of 2024, there was a paper about interprofessional learning, and that was really around. So Webster et al. Really proved that interprofessional teams that trained together and learned together had a real semblance of vicarious learning from each other, and it was not necessarily the formulaic curriculum. It was actually received wisdom from the different methods of practice, methods of reflection, methods of debrief. And we'll put links in the paper, actually, because this paper is hugely beneficial. Now, it's just prudent to say, and I'll get your take on this, actually, Mike, is that they weren't pre-hospital teams necessarily. They were interprofessional in-hospital teams. So potentially oncology working with rehabilitation, or indeed working with surgical teams, emergency teams working with rehabilitation teams. But there was this semblance of cross-pollination of learning and of understanding that was borne out in the literature. And anecdotally, I can attest to that in the pre-hospital environment as well. It was amazing to learn from some of my colleagues. Could I get you to speak to the power of training together in interprofessional teams and what that shows maybe through the literature?
Sure, and I think so. Craig's paper is an excellent paper, and I think I'll start there. So first off, I'll point out, which you may have glossed over, but that learning you experienced at London's Air Ambulance is bi-directional. I think all those people in the room learn as much from each other. So it's not just one way, but the doctors learn from the paramedics learn from the doctors. And personally, I think that is in part one of the reasons why we've seen what's happened with the profession of paramedicine in the UK and how it's advanced, and consultant paramedics, et cetera. I think that respect for and understanding of what the practice is grows when those people are in those settings. And as you pointed out, a stat that Craig quotes in his paper is that 90% of learning between professionals in the workplace occurs informally, unplanned, not through in an unplanned way, not through deliberate training, and it's mostly through working together in team-based multidisciplinary teams. And so I think it's that really there's that component. That's why I was going to push back to you about the shoulder to shoulder, and really, being there in the environment, problem solving together, decision making together, that provides these better outcomes for patients. And the paper, as you said, was in a variety of settings. which I find, really interesting because it was community medicine, it was diabetic care, it was oncology, it was critical care, yet the same finding is replicated again and again in these different areas, that when you bring professions together, and particularly around the decision-making piece and that delivery of care together in the moment, that it's really that's where you see this impact. So I do. That's why I think there you can potentially get some of that from some remote things, but I do think there is something about, particularly for critically ill patients, but also in the urgent care and the low acuity section, having that interprofessional team working together, whether it's a paramedic and a physiotherapist or occupational therapist or a midwife or a physician. There's these different combinations on the scene. The other thing this gets me to is, I don't know if you've ever had a chance to read Matthew Syed's book, Rebel Ideas, which is a great read if you ever have a chance. And Matthew, in his book, he's a London-based author that's written that plus Black Box Thinking and a few others. And I've had a couple of opportunities to hear him speak. He focuses in Rebel Ideas on what true diversity really means. And that sort of gets this piece around what interprofessional really means. There is something different than having just different flavors of the same. So, different people will say, well, we have different types of paramedics on scene, from technicians through to critical care paramedics. Is that diversity or not? And one of the things he points out in his book, he illustrates it with an example. I won't have time to go through all of it, but from the CIA, when they initially introduced diversity, they thought they were going to introduce diverse clinicians, so they selected for racial diversity, but all of their agents they hired still came from Ivy League school in the US. They all came from the same type of backgrounds. They didn't really have truly different types of thinking or different types of training and development. So they're really just, replicas of each other. And he talks about how that led them to some problems, and how someone who came in from completely the outside, who couldn't actually get recruited into the CIA, made a major change and finding for them in breaking down terrorism networks when she looked at the problem from a different angle. So there's that piece around what diversity means. And then he talks about why this diversity is really important. And I think, like I said, it really fits with the interprofessional type of approach. One is around breaking down information bubbles and echo chambers. So it's really introducing these different thoughts and different ideas, because I think within organizations, within professions, and again, it's both ways, you can get these echo chambers. You get, from LA, I'm sure a lot of the innovation that's happened there is because the paramedics drove the physicians and asked questions like, well, why can't we do that? Or why shouldn't we do that? And it breaks that bubble, and vice versa, the people pushing the other way. And then he also talks about VUCA environments, which you've probably talked about in your podcast before. So volatile, uncertain, complex, and ambiguous. And that to me describes pre-hospital care in its entirety. And why having diverse teams for decision making in critical, rapid decisions is so important in those settings. So those are some of the things that I think about when it comes to training, that it's about the experience you have when you're training, but it's also about the bigger piece about how training is developed, how it's shaped, the ideas that go into it, to prevent those echo chambers, to have a diversity of different thoughts. That's, all those pieces. And you get that, and a lot of that comes from working together shoulder to shoulder in the field, in that moment, particularly in the moment of crisis. And, we've sweated together on a few calls and gone through these situations, and how people come out of that, and the teams you form from that, I think is where some of the benefits that patients then receive down the road come from.
Just looking at the paper, Mike, did your analysis touch on the cost implications of deploying physician-led pre-hospital teams versus paramedic-only teams? I guess one of the segues here is that, it's a really difficult, maybe sometimes to analyze this, but fundamentally, if putting the same consultant emergency physician into a car or a helicopter, versus into an emergency department where they might see triple, quadruple the amount of patients in that same 12-hour shift is and it's not all about cost. Certainly there's multitude of added benefits to physicians in post-op care, but did it dig into any of that cost analysis at all?
Yeah, well, we certainly didn't do that in this paper. We had even reaching the word limit for this one paper was a challenge enough, but it definitely is an important issue. I did look at that in my as part of my MBA that I did looking at the cost of interprofessional teams versus uniprofessional teams, and in that analysis, and it varies a little bit by service to service, country to country, model to model, how you compensate people, who's compensated at what rates and different things. But and certainly the setting that I was looking at, it was not only cost effective, but it was definitely actually can lead to some cost savings in certain settings. The papers didn't, but then the grey literature there is work. So both Scotland, when they started their service, and Wales, both looked at cost effectiveness or value for money, and used the NICE criteria for evaluating, and found that it was well within the cost effectiveness for NICE for these types of models. And again, you have to look at sort of the broader system issues, like what are those overall system effects? And when I talk about these things, I tend to focus more, and I think what's more important is looking at value, and value defined as quality divided by cost. So sometimes there may be an incremental cost to delivering a service, but if the quality improves, and if you look at quality as impact and consistency or patient safety, the ability to have a greater impact and to do that consistently and reliably and safely, if you have that increasing, and that increase in impact, that increase in mortality, decrease in mortality, increase in survival is greater than a marginal difference in cost, the value for that service is better. And it really, as you mentioned earlier, this is really about targeting, and it's a yes and kind of answer. This is not, every ambulance should have interprofessional teams. This is, in London, it's 1 to 2 teams for 10 million people. So, how do you really target this, and how much? And I think that is where the cost effectiveness comes from. And I think there are services like Germany, which Johannes is working on, which is, the pendulum's too far the other way. It needs to come back more to the middle in terms of having fewer interprofessional teams, and really finding that sweet spot.
Yeah, no, indeed, actually, and he was describing that recently about how the utilization there is almost too many doctors in post-op care, and finding the sweet spot as far as the true utilization and the true effectiveness and efficacy in a very similar but different system. Like you said, there's certainly some changes I think ahead. But could we just speak to outcomes beyond survival? Like you said, it's very difficult. All this work is very difficult to actually look at multitude of primary and or secondary outcomes. But could I get you to, or indeed just get your thoughts on outcomes beyond survival? Just you did note sort of lack of studies on sort of provider satisfaction and economic benefits. Also, it's true to say convalescence and or rehabilitation, quality of life beyond survivability is sometimes a metric which is, maybe the gold standard, because it really is about quality of life beyond survival. Could I get you to speak to broadening the scope of the research into some of these areas?
Yeah, we actually have a paper that hopefully have out in the next few months, which looks at that, and it's just really a horizon scan of what outcomes are being reported right now. And there are outcomes that are being reported across much of the quintuple aim. And the quintuple aim, for those who are less familiar, is about obviously patient outcomes, so survival, mortality being the most common, patient experience, provider experience, and that's providers across the system. Also then cost effectiveness and addressing health inequities. So those are are the sort of the points of the quintuple aim. And I think we really should be driving to have research that addresses has outcomes across all of those measures. And there's more of them in the gray literature right now than there is in the published literature around these types of outcomes. But I think one of the things that in general, and there is a bit of work that started in pre-hospital care for this, but is to really start to look at sets of standardized outcomes that's used for all types of pre-hospital work, and so that people start to we were focusing on things that hopefully matter to patients, providers, funders, et cetera, but also because pre-hospital work and the challenge that it is tends to be smaller patient numbers. When you have standardized outcomes, you can then start to look at combining groups and studies and working more collaboratively is happening more and more across the UK, but also we need to do that internationally to be able to help improve the science of pre-hospital care.
Could I get you to speak to some of the systemic, Mike, or indeed logistical barriers that exist in implementing physician-led interprofessional pro-sport teams more widely? You said earlier, and I absolutely firmly believe, it's a yes and, which is, one or two teams in London. Sometimes there's 5 or 6 incidents, critical care incidents, and there is obviously a critical care paramedic-led team in London as well. But so it's almost this multitude of teams really responding to calls. Could I get you to speak to really the logistical and or systemic barriers to implementing physician-led teams?
Yeah, so I'll start with just the point you made at the moment, which is really having multiple different types of teams. And I think that's one of the things that we need to work towards, is to be able to have that diversity of teams and starting with that patient focus and say, what does this patient need? And being able to have that what I call the personalized medicine or the precision medicine of pre-hospital care, which is really tailoring the patient's needs, the teams and what the services that you're delivering them. And I often used to talk about, when I was in, around some of the hospital work, about the sickest patient in the hospital. When I talk about pre-hospital work, I often talk about the sickest patient in the province or in the city, and recognizing that sometimes there are patients out there that are so sick that have the potential benefit for a lot of gain, particularly something like a young trauma patient, that the system needs to be able to respond to them, needs to be able to push resources to them, the right teams, the right skill sets, and the right treatments to be able to give that person the best chance of a recovery. So having a system and moving away from some of what I call now the analog processes in pre-hospital care, which is, the static triage decision trees and things like that, which don't take into account anything about, well, what's the status of various hospitals and other issues and that's happening in the system, the lack of data. We need to move to much more dynamic systems that have the ability to target the resources when appropriate to patients. That's one of the logistics things. And I think, I'm quite inspired by some of the work that's happening in the UK and West Streeting's current mandate for change. And I think there's a lot in there that applies to pre-hospital care and that ability to, particularly moving from analog to digital, and the role of AI and other things to be able to help deliver more precision medicine in the pre-hospital setting. I think we touched on one of the other ones, so culture and attitudes. So one of them is that, which still exists out there, and a lot of it's, by our colleagues who are in hospital colleagues, is a sense of futility, like just sort of, well, you can't, these patients are going to die anyways, you can't really make a difference, and that sort of dismissing of what can actually happen in the pre-hospital setting. And so I think we need to overcome that. And I think we're getting there. Certainly some of the more recent work around ECMO, some of the work that even our US colleagues that have recognized that you can only do so much with scoop and run until we have time machines where we can transport patients, or the beam them up Scotty kind of stuff from Star Trek. We know patients, there's a window of time in which their disease physiology needs certain interventions to be able to make that difference. So we need to overcome those attitudes around futility and recognize the need for these. And then the tribalism and to a degree self-interest, and that's on different parts. So, the tribalism about not wanting to work together, keeping people out is one thing, but also the self-interest of clinicians and the system not wanting to really support pre-hospital care in the way it really needs to. And I think pre-hospital care has often been left isolated, and to deal with a lot of these really challenging, complex sick patients, but also difficult environments. And the hospitals get all the money and the bulk of the budget, and not a lot of the resources go to these other areas. So those pieces, the lack of awareness or knowledge amongst people about really what other systems are doing around the world, and the impact they can have, and then there's obviously the basic fear of change or unknown that we see in any systems change.
So looking at the future, Mike, you have already mentioned about the quintuple aim and, incorporating research which addresses that. Do you see that as sort of the priority for future research?
Yeah, certainly I think one of the areas to start with would be to say what outcomes should we be looking at. And the first question with that is what outcomes matter to our patients? And so I think that's one of the biggest areas. I'd be hesitant to waste too much time navel gazing and just thinking about just drilling down and looking only at ourselves and the systems and models of care and things, and saying, okay, well, let's accept that there's data out there that's showing interprofessional teams are beneficial. Now let's move to saying, well, where is that sweet spot of interprofessional teams? How do you get them to the right patients? And then what really matters for patients and the providers in the system, and improving that experience, care closer to home, increase or decreasing PTSD and moral injury by increasing support for pre-hospital providers as well as in-hospital providers in remote and rural areas. Those types of things are, I think, where a lot of the effort should be focused next in terms of research and system design.
Could I get you to speak to some of the ethical considerations that you mention in the study?
Yeah, so I think the big ethical thing that sort of comes up is around, how do you do future work around this and this idea of clinical equipoise, and does it exist? Because before you want to do something, a randomized controlled trial, you need to have equipoise so that you can ethically randomize to one group or another. And so we raise that sort of point in the article that in many of these systems, it may be difficult where teams already exist to say that you want to go to a randomized approach, and I think that that's sort of the ethical point that we raise. But also there's other issues in terms of just the methodology around trying to do RCTs and cost of it, and is it really the best way to do it? So I think in terms of the options, one of the things to certainly do is improve the rigor of existing observational studies. So things like standardized outcomes, but also looking at the data collection and collecting things like, what procedures were done and how many, and some of the finer details would be helpful. But even more importantly, what I think is really sort of ethically imperative is really driving towards learning health systems. So on a day-to-day basis, measuring outcomes, the importance of sharing the data and the outcomes that are measured transparently with the public, with others, and then looking at building collaborations so you can then combine that data to have significant enough patient numbers to be able to learn effectively across systems. So those, I think, are more of the ethical issues that come up.
No, indeed, absolutely, absolutely. Mike, it's been fantastic just to walk through this interview with you actually and just get your thoughts. I guess my last question really is around something we touched on earlier, which is really kind of real world impact and your anecdotal experience. I've got many experiences of as you said, bi-directional learning, learning from physicians on scene, them hopefully learning from me in some which way, but the being this really informal learning, actually, as you're saying, the way they hold themselves, the way they move, some of the lines of questioning, the reflections and debrief. So much actually, really, really rich. But could I get you to share some, or indeed one anecdotal example where physician-led post-op teams have indeed significantly improved either patient outcome or indeed the care experience?
Yeah, I think as we talked about, there are so many that we have from our joint experience, particularly with LAA. Your podcast, I think, was just last week where you talked about the Dan Richards case is a great example of I think that shared decision making on scene, and how having different minds and perspectives around the patient in the moment probably gave that patient a potentially better outcome than they might have had in a system that didn't have that type of collaborative care and approach. Since I don't want to drone on about examples. I recently presented a week or so, or actually a month ago, at the Canadian Critical Care Forum. Maybe you can just pop that link in the show notes for a more detailed walkthrough of a case example. And we have just about to be published our 21-year experience from LAA of thoracotomies, pre-hospital thoracotomies, and the outcomes there. And they're full of patients who would not have been alive in a different system. And I do think it's not just about it's not down to just one provider. It's about the system. It's about the team in particular that makes this happen. And that interprofessional nature of it that enables that type of care to be delivered. And then finally, the LA website has no shortage of, as do many of the air ambulance websites, KSS and others in the UK have examples of these patient outcomes. So I refer people to them to look for examples.
Mike, that's fantastic. Thank you for the past hour. It's great just to get your thoughts and indeed just dig into the research and indeed the future of research. So thank you so much.
Well, thanks very much for having me, and look forward to working together again soon.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.